Hi, welcome to Dr. Vic's Academy. Today we will be talking about cervical cancer screening. Introduction. HPV is present in nearly all cervical cancer cases. Furthermore, approximately 80% of adults will be infected with HPV in their lifetime. The virus is usually cleared by the immune system, but it can also cause cells to enter a proliferative state, leading to the development of cervical cancer. Cervical cancer screening. Most deaths from cervical cancer occur in women who are not adequately screened. In otherwise healthy women, screening should not occur until age 21 and should stop after age 65. Cervical cancer screening guidelines include three major age groups: 21 to 29 years, 30 to 65 years, and over 65 years. Women ages 30 to 65. There are two preferred screening methods for women ages 30 to 65 years. Cytology from a papillomavirus or pap test every 3 years. Or HPV testing every 5 years. Go testing with cytology plus HPV every 5 years is an option, but not preferred. Research has shown that the costs of more frequent screening outweighs the potential benefit. Choosing how to screen. Much of the decision between cytology or HPV testing comes down to a conversation with the patient, and frequently comfort with a prolonged screening interval influences the decision. Cytology. Liquid-based pap tests have largely replaced conventional pap tests, but there are no proven differences in outcomes between the modalities. HPV testing. HPV testing is very sensitive, but it is not very specific for risk of developing cervical cancer, as the majority of HPV viruses are cleared independently. Because it is so sensitive, HPV-based screening is only suggested every 5 years. Testing more often can lead to a higher cost and burden of care or more colposcopies without benefit. Women ages 21 to 29. Given the high prevalence of HPV in young women, HPV testing is not recommended for screening. The only option for screening women under 30 years old is cytology every 3 years. When to screen before 21. Healthy women should not be screened before age 21, regardless of initiation of sexual intercourse. HIV-infected individuals should begin screening at the time of diagnosis if sexually active, or at age 21 regardless of sexual activity. Women ages 65 plus. Older women are low risk for developing cervical cancer, so women who have been adequately screened can stop testing at age 65. Either 3 negative cytology tests or 2 negative HPV tests within the past 10 years are needed to stop screening. Other screening groups. Recommended screening among individuals who are vaccinated against HPV is currently the same, but this could change in the future as a larger proportion of the population is vaccinated. Following a complete hysterectomy, that was not performed for cervical dysplasia or precancer, no additional screening is needed. If a hysterectomy was completed for one of those reasons, screening should be continued with a vaginal swab. In the case of a partial hysterectomy, regular screening guidelines apply. Positive HPV screening. If a general HPV test is positive, the next step is HPV genotyping to see if the high-risk HPV strains 16 or 18 are present. If HPV 16 or 18 is positive, colposcopy is recommended. If the high-risk strains are not present, cytology is recommended. Colposcopy is recommended if cytology is abnormal, and retesting in 1 year for viral clearance is recommended if cytology is normal. Most HPV infections clear independently in 1 to 2 years. Cytology findings. The most common abnormal finding is atypical squamous cells of undetermined significance or ASCUS, seen on 5 to 10% of histopathology results. ASCUS is a common, non-specific finding where the cells are slightly tweaked. Normal vaginal flora, recent intercourse, or HPV can cause these changes. This can be thought of as indeterminate and not necessarily a precancerous lesion. If a SCUS is identified, there are two options. Repeat the PAP in 1 year, or reflex HPV testing. If HPV testing is positive, the patient should have a colposcopy. If HPV is negative, then their likelihood of disease is about the same as someone with a negative PAP, so they can come back in 3 years. Two other common findings on cytology are low-grade squamous intraepithelial lesion or LSIL, and high-grade squamous intraepithelial lesion or HSIL. LSIL usually represents a HPV infection. In about 10% of cases, LSIL progresses to HSIL within 2 years. This is more likely to occur in people who are 30 years old or older, compared to those in their 20s. LSIL can be managed with a repeat screen in 1 year or colposcopy, depending on the age. Check your guidelines. HSIL is caused by a HPV infection. Though not all HSIL will progress to cancer, it is considered a precancerous lesion and therefore is usually treated aggressively. HSIL always needs follow-up with a gynecologist for colposcopy. Colposcopy. A colposcopy is a procedure to examine the cervix. A colposcopy usually includes a biopsy. Potential side effects following the procedure include pain and rarely bleeding. Biopsy samples from colposcopy are sent for histopathologic evaluation. Biopsy findings. Biopsies are performed to look for histologic evidence of HPV infection and precancer, termed cervical intraepithelial neoplasia or CIN1, 2, and 3. Only CIN2 and 3 require treatment. CIN1 is left alone because it is equivalent to LSIL cytology. Both are evidence of active HPV that will hopefully resolve independently. Cervical treatments and complications. If CIN2 or 3 are identified, a procedure is usually recommended for treatment. Typical procedures include loop electrosurgical excision procedure known as LEEP, cryotherapy and excisional laser therapy. Risks associated with LEEP include a probable increased risk of preterm labor, a possible increased risk of miscarriage 6 to 12 months after the procedure, and no identified effect on fertility. HPV vaccination. Current guidelines: HPV vaccination starting at age 9. Individuals ages 9 to 14 should receive 2 injections occurring 6 to 12 months apart. Individuals over 15 years of age require a 3-injection regimen. The FDA recently approved HPV vaccination for women 26 to 45 years old, and guidelines recommend the use of shared decision-making in these patients. Those most likely to benefit from screening after 25 include adults with few sexual exposures at a young age at increased risk of exposure to new strains of HPV in the future. Those who have already had multiple sexual partners likely already have immunity to multiple HPV strains and will get minimal benefit. In summary, most adults are infected with HPV during their lifetime, but HPV is usually cleared by the immune system. Cervical cancer screening should not start before age 21 unless a woman has HIV. Women ages 21 to 29 should be screened every 3 years with cytology alone. There are 2 preferred options for screening women ages 30 to 65 for cervical cancer: cytology every 3 years or HPV testing alone every 5 years. The 2 most common cytology results, SCUS and LSIL, have a low likelihood of predicting future malignancy and usually heal on their own. During colposcopy, biopsies are taken for histopathologic evaluation. CIN2 or 3 are higher grade and usually get treated. HPV vaccine is recommended for patients aged 9 to 26, but can be offered to women up to age 45.
Audio Jungle. Audio Jungle.